In August 2024, I received an invitation unlike any other. Leaders from government, healthcare, academia, and industry had gathered at Eden Hall, the official residence of the British High Commissioner to Singapore, to discuss the future of genomic medicine across Asia. What I remember most wasn't the formal program, it was the conversations. Conversations about moving beyond discovery and into implementation. And one of those conversations began with Professor Datuk Dr. Rahman A. Jamal. Two years later, I traveled to Kuala Lumpur to continue that conversation. Professor Rahman welcomed me to UMBI, the UKM Medical Molecular Biology Institute, home to one of Southeast Asia's leading population biobanks, and to decades of work laying the scientific foundation for precision medicine in Malaysia. On the same day, through Professor Rahman's introduction, those conversations continued with senior leaders at Malaysia's National Institutes of Health and Ministry of Health, where we discussed a shared vision for accelerating precision medicine across ASEAN. Okay. Professor Datuk Dr. Rahman Jamal, thank you so much for joining me. You've spent decades helping shape precision medicine here in Malaysia, from building research infrastructure, national collaborations, and most recently launching the Malaysian Pangenome Project. Today, Malaysia sits at this fascinating point in its precision medicine journey, and I'm excited to explore what's ahead. So let's begin with the big picture. When people outside of Southeast Asia think about leaders in precision medicine, they think about the US, the UK, perhaps Thailand and Singapore, but you've been quietly building something remarkable here in Malaysia for decades. How would you describe where Malaysia sits today?
Well, thank you, Kathleen. I believe Malaysia is sitting on a gold mine in terms of diversity, in terms of resources, in terms of talent. I believe there's quite a bit of organization we need to do, but I think we are on the right track. As you said, we have built the platform and resources. If I'm talking about UMBI itself, we have built a population-based cohort, a biobank that collects specimens at baseline and at follow-up. And this is an important backbone for precision medicine. As you know, any precision medicine applications requires a local reference. And because we have collected from so many of the ethnic groups and also know the outcomes over the period of 15 years, I think this is both opportunistic and strategic for Malaysia. Got the outcome data, we may be at the early stage of doing sort of the genome profiling. And I am happy that besides our Pangenome, there's also the My Genome Project under the Ministry of Science and Ministry of Health. And I think with these two genome initiatives, soon we will have a good and comprehensive reference genome for us then to make the right sort of analysis or reference when we work on polygenic risk scores, pharmacogenetics, cancer variants, cancer-related variants, and so on, rather than depending solely on the Caucasian Western data. Kathleen.
It's an extraordinary foundation. And just for the benefit of our listeners, I mean, you and I share this passion in population genetics. I think so much of the world just doesn't appreciate the diversity in this part of the world. Can you say a little bit about, with regard to the Pangenome Project, the diversity of Malaysia? What has been untapped until now? And just say a few words about the population in general.
Malaysia is not a single story. So although we have the three main ethnic groups, Malays, Chinese, Indians, but we have within that three major ethnic groups, sub-ethnicities. For the Malays alone, we have more than 35 sub-ethnicities. I think we know this from Javanese, Bugis, Aceh, Minang, Riau. Though the Indians and Chinese genomes are now being characterized not only by India, China, and also Singapore. But in addition to that, we have Sabah and Sarawak. That's a huge gap because in Sabah and Sarawak alone, there are sub-ethnicities as well, not explored before. And we also have the Aborigines. I believe if you count the sub-ethnicities in Malaysia, it would almost reach 200 sub-ethnic groups. So in our pangenome, we had a representation of 56 ethnicities under that. We believe this is our strongest potential. Hence, we believe that the pangenome will at least be a good start to representing Malaysia and also add on to the gap in the global genome database, which you mentioned. There's a big gap from this part of the world. So, and in our early analysis, we have picked up almost 8 million new SNPs, which have not been sort of recorded in the SNPs database.
Wow.
This is good because we can add that data to the missing or the gap that's in the global SNP database, Kathleen.
Yeah, absolutely. I'm just curious, how do you define the ethnicity? Is it language based? How do people self-report in specific ethnicities?
So when we started the cohort nearly 20 years ago, we already thought about ancestry. Somehow genomics was just coming in then, and we believe if we were to embark on a future ancestry base or a genome reference, we need to really make sure the ancestry is well defined. So we asked each one of them in terms of their ethnicity. Most of them would know because the parents would tell them. And then the ethnicity of or sub-ethnicity of their parents and the grandparents. These three generation sort of designation in terms of. And for the pangenome, we only chose those who showed or who claim or self-report the same sub-ethnicity group at 3 levels of generation. I think this is the strength of the Malaysian cohort that is not present in other cohorts. In terms of getting generational data, if you were to really map, the sub-ethnicities when you analyze.
You're leading the Malaysian Pangenome Project. How are you and your team, how do you interact with the other, scientists around the world who are similarly working on the pangenome?
I think since we launched our pangenome, there have been interest from other groups that are working on Pangenome, including the Thailand group, the China group, the Philippines, and of course I've been interacting with the Singapore Precise as well.
Sure.
And I believe there's a lot of potential for comparative analysis, best practices, and including analytical sort of pipelines. And I believe there is an opportunity for an ASEAN-based alliance or consortium to sort of work together strategically to sort of to see how we could use this rich database or reference genomes to translate to precision medicine better. Kathleen.
At the end of the day, when this project is complete, can you say a few words about specifically how that is going to lead to precision medicine tools?
Okay, I'll take an example because I think you and me are passionate about pharmacogenetics. Our clinicians are always asking us for evidence. If we say they need to start doing analysis, pharmacogenetic analysis for a drug, like before they prescribe a drug like clopidogrel, where is the evidence that a certain allele is common? So that's what exactly we have done. We have done this from our genotyping arrays, but we believe our pangenome data would add on to this evidence. So from our genotyping arrays, we know that the CYP2C19 star 17 is highest amongst the Indians, 17%. Imagine 1 in 8 patients treated with clopidogrel have not had their pharmacogene allele done. It is just for trial and error. So this is affect both the risk of lower dosing and also adverse drug reactions. I think that's a small example on how we could precisely show that for a particular application, and in this case pharmacogenetics, you need local data. One, to apply it accurately. Number two is actually to provide the evidence for our clinicians to get the buy-in and say, yes, I can see that this is important for my practice. So since I've showed this data on the pharmacogenes for clopidogrel, in terms of the allele frequency in 2 conferences. Latest is a pharmacy conference focused on cardiac medicine. I think there's been a lot of awareness in terms of how this pangenome can help provide the evidence so that we can really give a value-based sort of healthcare to our patients. Kathleen.
That is such a great example. And just as a point of reference, what is the target number of individuals from Malaysia that you anticipate for the Pangenome Project?
Oh, I wish I could do more. I think the limiting factor is the funding. With such a diverse population, I believe 4,000 is not enough. Even though we have T2T, and 3 of them are Malays, 2 for Chinese and 2 for Indians. But I think the 4,000 is a good start, and maybe we could do more, but not deep. But a low pass sort of sequencing for the next 10,000 or so that we can have a good reference that researchers can have access to. Kathleen.
Yeah. Rahman, from our recent discussions, you said something that really struck me. Malaysia has the science. Malaysia has the technology. Malaysia has the patients. But bringing people together is not easy. Can you say a bit about what you mean by that?
We have been working sort of uh, in groups, in different groups, whether we are at the Ministry of Higher Education in the universities, Ministry of Health, or Ministry of Science. I don't want to highlight that as a problem. I believe each ministries have their own priorities, their own resources, and I believe this is a good time for people to come together. We've shown that during the pandemic, we brought the ministries together. Upscaling the tests, and in fact, we were involved also in genome surveillance, and I could see then we brought all the labs from the three ministries together, the researchers, the resources, and so on. And I'm optimistic that Malaysia can get this done. We need champions. We need champions certainly from each of these ministry, and also an agreement to work together. And I think the ecosystem, the climate is good for this. But I think this must be done in a win-win situation, because everybody will be very, because they've done a lot with their data, both the phenotype and the genotype data. We must find a way to bring all this data together, so that everybody feel that they have contributed, and also they have a say in terms of data access and data sharing. So I think there's a possibility there, because now there is the federated approach to data analysis and so on. And I am positive, Kathleen, this can be done and achieved, so that Malaysia can be a major player in precision medicine at the ASEAN level. Yeah.
It feels like it comes back to this whole notion of it takes a village. I had this remarkable conversation with a thought leader in Thailand last week on that. Many countries have developed excellent strategic plans, roadmaps, task force, white papers, but relatively few have successfully implemented precision medicine at scale. Why do you think implementation is so challenging?
For me, I think there are many best practices already around us, and I believe in Malaysia the private sector is already implementing that. Although I believe this is only about maybe 10-15% of the population that needs it, and it's still out of pocket payment. My personal opinion of this is there must be a link to the reimbursement of the healthcare within the healthcare system, and because doing the genetic testing and so on requires funding, a resource, and then for some of them like cancers, you will also identify actionable mutation that requires targeted treatment, that also requires funding. I don't think testing is a big challenge now because there's so many platforms. We must show the return on investment. We must show cost effectiveness. We must show budget impact analysis. And this is where I think again we must bring the health economists to work with us. People like me can show the evidence, can show the allele frequency, can show how we can identify actionable mutations, diagnose rare diseases, but they need to work out, the health economists needs to work out the cost effectiveness of this. There are many papers from Australia, from US, for rare disease, it's a cost savings. a single whole exome sequencing can identify the mutation compared to an array of tests that turns out negative. So same like for cancer, where an actionable mutation can provide remission for those who do not respond to treatment or also become resistant to treatment. I think that economic angle is one of the biggest obstacle to implementation.
One of my favorite comments from one of our earlier conversations was, we don't need workshop after workshop. We don't need policy paper after policy paper. Can you expand on that?
Well, I always believe that there's already best practices. There's evidence of implementation, elsewhere, including things like applying next-gen sequencing in the critically ill, NICU, PICU. These are best practices, and it showed, how many percent of these cases have been diagnosed early on and could be intervened. I believe there are many others as well, including pharmacogenetics, precision oncology, precision cardiology, right, in terms of familial hypercholesterolemia, for example, right? Singapore has shown from the precise study, 1 in 140 of them has FH, and they have embarked on, they have set up a children lipid clinic at Kandang Terbau. I visited them because they know early intervention can save a lot of life from coronary artery disease. And 1 in 140 is higher than the global average of 1 in 300. Malaysian population would be similar to Singapore in most ways, in most aspects, which means we need to decide on the fact that we need this such training program as well. So there's no need to gather more evidence, because Singapore, in terms of population wise, and I believe I can bet my last dollar that the FH prevalence is still about the same, 1 in 140. So that's what I mean, where evidence is already there, targeted treatment is already there. I think it's already implementation time. For certain aspects like finding out, the allele frequency for some of the variants that we've not known or unknown for Malaysia, yes, that must go on. But I think workshops like this may be important in terms of the platform for testing, the quality control, what kind of regulatory mechanisms, so whether they need ISOs, whether they need, CAP, because this is important to lend credibility to these labs. And then policies such as reimbursement, I think this is important.
I mean, a great example of that is, every day physicians prescribe medications that, and you've already given a great example, that we know are influenced by genetics. But pharmacogenomics or PGX, it still isn't routine across almost all of the world. Why has this become a priority for you?
Well, to me, it's a low-hanging fruit. It's a low-hanging fruit. And we talk about adverse drug reactions, admissions due to that. We talk about underdosing and so on. And then our oncologists also wonder how they could provide precision treatment. So that's what, and being a pediatric oncologist, I believe this is something not rocket science anymore, because the technology is simple. Even with a TaqMan technology approach, PCR based, you could bring the cost down, even just for the SIP2 C19, let alone the others, UGT1A1, the DPYD. So for me, at the personal level, I see this as a low-hanging fruit that can be rolled out quickly, and providing a cheaper alternative to the large pharmacogenetic arrays that are commercially available. They're good. They give you the database, your own personal, information should you be prescribed other drugs. But if we start small, any good molecular biology lab can actually develop this at low cost without spending thousands, on the kits that provided by the major platform providers. I think that's important because we help the clinicians to really tailor their treatment, and not risk adverse reactions in their patients, Kathleen.
Some of the most exciting implementation of precision medicine in Asia seems to be happening with private health systems. And what role do you see private hospitals playing in accelerating precision medicine?
I think they're doing a good job because they are giving patients, whether they have cancers or rare disease, a chance to get better treatment. But in healthcare, you talk about equitability, you talk about access. Um, the bulk of the population that needs precision medicine is still in the public side. But I think the private hospitals and the labs are are already doing a good job in offering this precision medicine related testing, and this all goes well. But uh, people will say the price is still expensive. But I don't blame them because of issues of batching, turnaround time, overheads, and so on. But on the public side, I think there's an opportunity to work together with them. And for me, at the personal level, I have been engaging both companies, and also labs, private labs, in terms of collaboration, to try to bring the price down and make genetic testing affordable, at least until a reimbursement system sets in. I think this is important, and from what I gathered through my conversations with this private lab, they are willing to work together with a public lab like UMBI, or where I am, to try to find a cheaper solutions, or at least merge our samples to provide a faster fulfillment of the batch, uh, because many of them have a very high throughput machines or platforms that require more volume. So I think there's an opportunity to work with them whilst also working on our own solutions, in-house, that would provide affordable testing for the bulk of the population that needs it. But bottom line, I think they're doing a good thing, providing access to the private patients, and some of the public patients who can afford. But still, I think we should work towards equitability and accessibility to the majority of the population, Kathleen.
Rahman, do you think precision medicine has reached a different era?
I believe so, and because to me it's now action time. It's now implementation time. Maybe in the past decade it's still data gathering, evidence gathering, and finding for cancer, still finding the partner drugs for. But I think at least for many of those applications, it's action time. It's already doable, even in the low middle income countries. It used to be, we thought, for some of the tests we need to send overseas, to the developed nation, but no more. I think even a low middle income country, with the technologies now, the platform that's easy to use, inbuilt report generation system analytics. I think it's changing the game. Except the issue is still who's going to pay for this. But I think the cost of sequencing is coming down. People are talking about $100 sequencing, which is unimaginable. So, and somebody is talking about a $10 sequencing. I was told by my colleague from Cambridge last week. If this comes into reality, everybody can have their genome sequencing done, including newborns or even healthy people, to know their risk of developing disease and so on, let alone those who have diseases. It could fine-tune their treatment and also prediction of their complications. So I think it's really have changed. We are entering a new era with, I think UK, Singapore is taking a huge lead here with their newborn sequencing programs. Of course, we would love to do this in this part of the world, but I think with the cheaper sequencing costs coming, this may be possible. And taking the Air Asia slogan by Tony Fernandez, now everybody can fly with the low cost flights. I believe one day, everybody can have their genetic testing done. Okay.
I agree. Uh, when a genome is cheaper than a CBC with diff, right? what is standing in the way? Rahman, no country in Southeast Asia is identical. The healthcare systems differ, funding differs, policy differs. Even the underlying genetic diversity, which we've talked about, differs. But many of the implementation challenges are remarkably similar. What opportunities do you think exist for countries across ASEAN to learn from one another rather than reinventing the wheel?
Okay, I see this as an opportunity for two different tracks. One is our own, is the alliance from the professional side, academicians, researchers, scientists, and we meet each other. I think even now we know who are the players for certain areas in Thailand, Indonesia, Singapore. I think forming that alliance is not difficult. We need champions because we need the first mover. We need somebody to. I think that's one way where we could share resources, share expertise, and so on. As I mentioned, I met some of the Thai researchers 2 weeks ago, and they were running. They're already running the Masters of Science in bioinformatics, at their institutions, and they were offering in terms of, if we need resources, if we're going to run our own course in terms of visiting trainers or lecturers, they're open to that. I'm sure the other ASEAN nations will be willing. So to me, that's the professional track. But on the other hand, I think the official G2G, or government to government, can play a role, ASEAN level. But getting an agenda into that kind of ASEAN level meetings is a challenge. We need to get a buy-in, because at the ASEAN level, of course, there are many agendas, and there are many also sub-meetings, health, economy, environment. But this is where we need to lobby to our minister. If you're like me, I have to lobby to our Minister of Higher Education and also to the Ministry of Minister of Health. And I think that's the official agenda. But I think there's an advantage of that at the ASEAN level. It becomes something that will be regularly monitored, and there will be regular meetings. And if that is approved, then they would then this will be trickled down and the professionals and the policymakers would come together. So I believe both ways can work in addition to our own personal contacts. It may not be ASEAN level, but at least it's between Malaysia and Thailand group, Malaysia and Singapore group of researchers working on a particular area. And I believe all three has an advantage of their own in terms of coverage, focus, and also the implementation, Kathleen.
Rahman, let's imagine we're having this conversation 5 years from now.
Okay.
What would success look like for Malaysia?
I believe if we have a social healthcare reimbursement system in whatever forms, that means that could support, genetic testing, and of course the link to targeted treatment and so on, whether public or private, but mostly public, so make it equitable and accessible. I'm positive in 5 years' time we would see routine pharmacogenetic testing for the common drugs, the drugs that are used mostly by our oncologists, for example, 5-fluorouracil, irinotecan, and then by our cardiologists, clopidogrel, warfarin, whole next-gen sequencing for rare disease, newborns who are critically ill in ICU, and this would be all tested and reimbursable. And who knows, there would be a similar newborn screening program, although I'm a bit over-optimistic there. But it could be possible if truly the cost of sequencing would come down. What we need is, from now, is increasing the awareness about this to the public, and also educating also our clinicians and the public as well. And I believe the stakeholders' engagement is important. For us researchers, doctors, and so on, we may believe this is important, but it is a good time to engage the stakeholders, the patients group, the man in the street, whether they understand or not how genome actually is, plays a big role in their lives, and for them to be aware that they can intervene this when they are healthy, not wait for them to be ill. So I think those things can be done now, so that what I mentioned 5 years from now would become a reality. And I hope I'm still around working then to see the the impact.
I hope both of us are.
Yeah.
Rahman, finally,
Okay.
if a minister of health or a CEO of a hospital or a national policymaker is listening today, what one piece of advice would you leave them with?
I think for them to believe that precision medicine is already transforming healthcare in many of the developed nations, and coming up in the developing nations, including the low middle income countries. I wish they would sort of support a national level agenda, and link this with digital health as well, because we need to link with outcome. Hence, the electronic health record, electronic medical record would be important to link with whatever genomic data or other multi-omics data. And if we do this now early, we would see the return on investment and the return on value, ROV. It may not be money, but it would be about quality of life, productivity, life years, and that would really put Malaysia, on a track to a healthier nation, Kathleen.
Professor Rahman, truly Malaysia's lessons. There's so much we can learn
Yes.
from your experience. So thank you for sharing it with us.
Thank you, Kathleen. Yeah.
Thank you for this opportunity. Thank you for joining us on Precision Health Decoded.
Okay. Thank you.